I'd like to review some information about epidural hematomas. Before then, I just want to make sure that we are all on the same page with respect to the etiology of epidural hematomas. As you can see, epidural hematomas are usually due to a defect in the arterial supply, usually the middle meningeal artery, which leads to the lentiform shape of the epidural hematoma overlying the temporal lobe. However, the alternative etiology is a tear in the venous sinus where blood collects outside the dura. Contrast that with the subdural hematoma where one has a collection which is deep to the dura from small veins that are torn. For those of you who like a little bit more of an anatomic explanation, here we have a description of the anatomy. You see that we have the skin surface and then the skull, and we have the meningeal artery, which is outside of the dura here. In this situation, a collection outside of the dura would lead to an epidural hematoma. Here we have a collection which is superficial, again, to the dural margin here in the epidural space. And you would contrast that to one that is deep to the dural space with these bridging veins, which would be in the subdural space. The indications for intervention for acute epidural hematomas are similar to that for subdural hematoma with a few exceptions. We note, as in this example, that an epidural hematoma that is greater than 30 cc's would be an indication for surgical intervention. So once again, we would have to give our best guess as far as the 3 dimensions in AP, right, left, and superior inferior dimension and divide that by 2. However, an epidural hematoma that in one cross-section is 15 millimeters thick or more, or one that leads to greater than 5 millimeters of midline shift, usually at the level of the septum pellucidum, would be an indication for surgical intervention as well. Just want to remind you that when I spoke about subdural hematomas, the thickness was only 10 millimeters, whereas for epidural hematomas, it's 15 millimeters. Again, this suggests that the prognosis for those patients who have subdural hematomas is worse than those with epidural hematoma in that the surgeons are going to operate earlier on subdural hematomas than epidural hematomas. Remember also that there is the typical shape and location for an epidural hematoma. This is showing that biconvex appearance to an epidural hematoma, typically over the temporal bone, because that's along where the middle meningeal artery runs. And that's to be contrasted with the crescentic appearance of a subdural hematoma. In this case, the patient has a intraparenchymal hematoma as well, and likely has another collection outside the brain on the right side. These are 2 examples of epidural hematomas. One arterial. Which one do you expect? The A is actually not for arterial. The A represents an arachnoid cyst. This unfortunate individual had a traumatic epidural hematoma over the left hemisphere, as well as an arachnoid cyst. Crescentic in shape over the temporal bone, unrelated to the patient's arachnoid cyst. This swirling nature of the blood products suggests active bleeding. So when you see heterogeneous density to the collection and a kind of a swirling pattern, that suggests active bleeding, and it may encourage the surgeons to go in to evacuate it. The patient also has subarachnoid hemorrhage. This patient on the left-hand side of the slide, you can see has a collection which is crossing the midline. Well, we know that the falx normally would separate midline structures. So this collection must have dissected across the falx and crossing from right to left. Therefore, this is an epidural hematoma, not a subdural hematoma, which will be defined and cannot cross the falx. And this is one due to trauma to the venous sinus. So I want to make sure I make this clear that venous sinus is epidural hematoma, yet bridging veins is subdural hematoma. Non-surgical management would be epidural hematomas who have a volume of less than 30 cc's or less than 50 millimeters thick and with less than 5 millimeters of midline shift and are stable clinically. This is another example of a patient who has an epidural hematoma demonstrated as a biconvex collection, in this case mixed collection, in the posterior fossa. As you can see, in this situation with this collection, we're going to look and see where there's mass effect on the fourth ventricle, effacement of sulci, displacement of the basal cisterns, and that may be an indication from posterior fossa lesion of any type, be it a parenchymal hematoma or a subdural hematoma or an epidural hematoma. This epidural hematoma was secondary to transverse sinus disruption.